So I'm Glenn Hazelwood. I'm one of the co-chairs of this group. And this is, I'm very new to OMERACT. I've been sort of familiarizing myself with it over the past year since our group formed, and have been involved in some of the sessions. But this is our first SIG with this group. So we're really excited to show you what we've sort of present the background on our group and what we've done so far. And so we'll be trying to monitor the chat as we go and leaving lots of chances for discussion at different points within the talk. Okay. Oh yeah, thanks, Megan. You have to advance it. So yeah, no disclosures. This is the membership of the group so far. Hopefully this will grow after today. So please reach out after this if you'd like to join. Okay, so we want to start with a poll. Just to gauge people's knowledge of preference-based methods. So question is, how would you rate your knowledge of preference-based methods and their application to outcome measurement and clinical trials? Oh, and I think, okay, very unknowledgeable is at the top. Just, okay, very knowledgeable as well. So Bev, does that show up on the?
Once everyone's done, we'll.
Yeah. Once everyone's done, okay, perfect.
They all filled in, Shauna. So we'll post the results now.
Yeah, we're at 32 of 37. I'm just giving everyone a second to make sure they see the poll. Sometimes you need to move your sort of your window over a little bit. So just make sure. So I'll end it now.
We give people time. There we go.
Okay, perfect. So fairly normally distributed, I'd say, around the average. Okay, so we will be asking that again at the end. So hopefully people's knowledge will have gone up. Okay, next slide again. So we wanted to start with some examples of how preference-based methods where they may be useful in outcome measurement in clinical trials in rheumatology. And so the first one is not an example of it being done, but I think illustrates really well the potential role for patient preferences. So you can click, Megan. So in non-inferiority trial, so a non-inferiority trial is a trial where you have a new treatment or new treatment strategy that's better in certain respects. So oftentimes it's lower cost or has other advantages. And you want to make sure that that new treatment isn't worse in some other way, or it's not non-inferior. Megan, yeah. So a really good example of this is with treatment tapering. So there's lots of trials coming out looking at drug tapering in rheumatoid arthritis. And there's inherent benefits to it in that patients can be on less medication. But it's critical to ensure that tapering doesn't result in an important increase in flares. So I thought this was this is a quote taken from a recent randomized trial. And when they selected their non-inferiority margin, they decided that a 20% increase in flares would be the non-inferiority margin for their primary outcome, because in their clinical view, that seemed to balance well with an expected chance of being able to reduce the dose or stop the drug of 60% and 15%. So this is the investigators sort of making these trade-offs. And this is really a situation where patient preferences could play a role. Okay, Megan, you can go to the next slide. So I'm going to pass it over to Nick now to talk about the second example.
Thanks, Glenn. I think this is just another example which is around sort of developing composite outcomes. Now, composites can be controversial in trial design, but I think for some trials, they make a lot of sense. Like this is an example not from rheumatology, but for treatment of hypertension in pregnancy, where there's outcomes of both the mother and the infant, which are both important. So I think it's a natural example of a composite. And so in this example, which was actually led by a PhD student of mine, Rebecca Metcalf, we worked with the investigators of a large multinational trial which had already completed, did qualitative work with patients to understand which of the outcomes mattered most, which those are on the right-hand side. Then we did some preference elicitation of a large sample of pregnant people to sort of find their sort of informed preferences for these sort of trade-offs between these outcomes. And whilst most composites assign equal weight, and when you do this, I think you find that actually the two treatments were equivalent. There was no difference. But then we actually explored the preferences further and found patients fell into one of three groups. And in one of these groups, this profile 1, if you go on, Megan, you know, this group as well, if you keep going, Megan, this group, there was similarly no difference. But if you go into the next group, gosh, there's lots of things going on here. Yeah, this profile actually found that tight control was preferred for them in their preferences, which is one of the treatments. But if you go on to the last profile, this is people who sort of were avoiders of medication. You actually found that less tight control was the sort of optimal treatment for them. So the same trial had very different results based on the preferences of those included. So that's just another example of how preferences can matter in the interpretation of a trial.
Okay, great. Ligana?
Thank you very much. So here's a different example. And in this study, we sought out to describe how patients feel about different side effects. This was the first step in a study looking at how to measure a global outcome or global experience on medication so patients could better compare, as what Nick just said, you know, a new medication compared to old medication. And as many of you know already, in randomized controlled trials, people report frequencies of a really huge list of adverse events, some which we know really are completely unrelated to the medication, and so really don't help inform decision-making as much as they could. And so what we did is we surveyed a large number of patients, giving them various types of survey questions that allowed us to say, so which medication side effects, you know, impact people's quality of life the most compared to the least, and generate a rank ordering of that. So you can see here in this figure that level 1 is the best. That is, you have no side effects from medication. And level 9 is the worst, where you have a serious complication that results in sort of long-term problems and requires ongoing treatment. And interestingly, we also conducted this study to allow for there to be equivalence classes. So if you look at row 3, you can see that there are several side effects that patients felt had a similar impact on their quality of life. All of these were rated on their quality of life. So you can see here with this type of approach that instead of just sort of, you know, creating a table with frequencies of side effects, we can get smarter at this and learn from patients what really has the most impact on their quality of life and how to group those together so we can report trials and compare newer treatments to older ones and sort of create side effect profiles that are likely related to the drugs and that would allow patients to say whether or not they would rather a drug with a lot of people falling in row 3 or row 4, etc. And so this would be a tool where clearly you would need patient preference to create this type of adverse event hierarchy.
That's great. Thanks, Liana. I should mention too, please type questions in the chat as you have them. We'll also have times to speak if you have questions, but we will monitor the chat as we go. So as you've seen, patient preference methods are really a toolbox that we can use, we think, at multiple stages of outcome development in clinical trials. And it's a way to help inform these decisions through the eyes of patients rather than physicians or trialists. So what is a preference? So a preference is essentially a greater liking for one alternative over another or others. And in a healthcare context, we're talking about preferences typically for treatment or other attributes of the care that people receive. And preference-based methods are a way to quantify I think this is really an important distinction. Is we're really talking about quantifying these trade-offs, preferences for these trade-offs, as opposed to other types of research that you could look at patient preferences like qualitative research or other types of surveys. Okay. And so this is a gross oversimplification of the different types of preference-based methods. But you could kind of, one way of grouping them is to think of them as methods that look at one health dimension at a time, and others that look at multi-dimensional decisions. So I'm going to walk through examples. So an example of the first, a classic example is a standard gamble. And so I don't know how, everybody's probably heard of a standard gamble, but I don't know how many people have actually know what it looks like when you're doing a standard gamble. So these are typically elicitation exercises you do in person with people. And so this is an example where you're asked to imagine that you have severe rheumatoid arthritis and problems with walking, self-care, daily activities, etc. So there's sort of a description of a healthcare context, and you probably want to, we've simplified it for this slide, but you provide maybe more details around that. And then you ask people a choice, and the choice is two options, so choice A or choice B. In choice B, you essentially stay in that health state for the rest of your life. And in choice A, there's some gamble associated with it. So there's a chance of instant death, and there's a chance of being cured of your disease and returning to full health for the rest of your life. So Megan? And so in a standard gamble, what you do is you vary those probabilities. You can go in there, yeah. You vary the probabilities associated with choice A until you find where people are indifferent. And that gives you a value that you can place on that health state. So in this situation, we just wanted to put out a poll just as an example to get people thinking of how patients would do these. So we could open the poll now. So in choice A, you're thinking of that health state of rheumatoid arthritis we described, and whether you would take the treatment, which comes with the gamble, or remain in your current health state. There's no right or wrong answer. Okay, pretty split. Interesting. So then you would, the idea is you would adjust those probabilities for a patient until you found where people would, or where their point of indifference is. Okay, again. So this is an example of a discrete choice experiment, which is a type of stated preference. So in these, you're essentially presenting different options to people, and you're asking them to choose which option they would prefer. So this again would be a situation where you're, and there'll be some sort of scenario you would give to people. So this would be a patient with rheumatoid arthritis whose disease is active, and you're trying to choose between treatment A or treatment B. Treatment B has a higher chance of improvement. So it has a 60% chance of improvement versus 40% with A. But for treatment B, you have to take injections instead of pills. You have to, there's a higher chance of having a side effect, and you need to limit your alcohol consumption. So again, we'll open it up as a poll to see which treatment people would choose. Yeah, Maria, you have a good point there. It depends on how worse the current state is. You're right. So you typically need a very specific scenario. So for this, you could imagine somebody with rheumatoid arthritis and say moderate to high disease activity, without going into too many more details. Okay, so again, pretty split. Just over half of people would choose the one that had the higher benefit, despite the other negative aspects of it. Okay, so where is the gap? And this is really where we're talking about what role this group can provide. So I think, as we've shown a bit in the examples, but also in the published literature, really these patient preference studies and work is typically done at the end of the trial, after the trial has been published, or by a group that's independent of the study. So really, we think the gap is, how can these methods, Megan, you can click. How can these methods be applied within the trial so that when we're generating the evidence, we do it with patient preferences in mind. We wanted to make, this is, I think, a really clear distinction. When we're talking about patient preferences within the context of this group, we are being fairly focused on it because we know that outside of this group, there's a lot of work that OMERACT does in terms of patient engagement. So really by patient preferences, again, we're referring to those quantitative methods and how they can be used. Patient engagement is critical. Anytime you're doing a patient preference study, it will certainly be critical to the work of this group, but it's of course a much broader concept. So yeah, so our aim is really to build consensus and develop guidance on how we can use these methods related to outcome measurement in rheumatology. And maybe we'll stop there for some discussion.
Yeah, that's good. There's a couple of good points in there that maybe we can read out, and then if people want to jump in. And Diana, you had a good point about patients could also be divided into categories of low, medium, or high risk willingness to take that risk.
Yeah, did
you want to jump
Leanna, I know you've done a lot on this. Did you want to just give some of your thoughts on that?
Yeah, I think that's a really great example, actually. And I think the differences in how those would translate to what you might prefer was really nicely shown in Nick's slides before. So that, you can actually measure those risk tolerance profiles. And you could theoretically do that at the beginning of a trial, and that might be used to determine, at what point these various cutoffs might be drawn, for example. Which outcomes are appropriate, how much risk should we be willing to take, and that might differ across groups. I would caution, though, that as Glenn said before, these are methods that we want to include at the beginning, and not necessarily that a patient would have a characteristic that they would be either somebody who really is willing to risk a lot to get back to a healthy state versus somebody who might be more risk averse. So we'd have to think about how would we measure that and use that information at the beginning when we're designing a trial, as opposed to an individual patient trait. And the latter actually can also be context dependent. So patients might be more risk seeking at the beginning of their disease and more risk averse later on, for example. So I think that's a great example of something that we could incorporate. Thank you for the comment.
And Catherine Hostetter said, what part does the duration of the disease play in this? And then Maria had answered that it depends on how worse it is in the current state. And Maureen said to that it might depend on age too. So do anyone want to comment, or do you want, if anyone would like to speak to those comments, please feel free. Kathy or Maria or Maureen?
Yeah, certainly clinical and as well as, and actually almost more so in a lot of patient preference studies that are done, is sociodemographic variables that are associated with different preferences. Touching on Leanna's point, I think there's certainly predictors that can predict preferences, but we want to be careful again at the individual patient level to sort of lump people into, based on characteristics they would, because, you can have elderly people that have very different preferences based on their.
Great. Kathy, did you want to say anything about the state of health comment? I think that's important for people to hear as well. No.
I was just, I think for me, it's just thinking back, I'm 28 years into this, that my preferences have probably changed 100 times. Looking at those questions over the years, my preferences would have changed 100 times back and forth, and not necessarily how bad the state of my disease was at any given time, but how able I am to cope with it.
Great, thank you. And Grayson, as always, you have amazing comments. Do you want to synthesize that for us? And
yeah, sure. I think one important thing to take into consideration here is ableism, right? So discrimination, real or perceived, against a group of people who have a chronic illness, disability, etc. That can easily tint someone's viewpoint of what their current state is, of any possible future state that exists for them specifically. You know, if you're living in a space where, let's say, you're dependent on a partner or a parent or a sibling to help care for you, and that sibling has resentment and shows it through very harmful rhetoric that they share, that is ableist in nature, you're going to have a very different viewpoint than somebody like me who is stable, doing well, whatever. And actually, there are a lot of cultural factors to that as well, because different marginalized cultural communities interact with disability and chronic illness in different ways. So, you know, I see this a lot in the HIV/AIDS world. A lot of people in the Black community talk about HIV/AIDS as a cancer. And so when they're talking about it, they're never being quite as linguistically precise about it. And there's a lot of kind of talking around what the issue actually is. So that might also tint somebody's ability to feel like they're being able to share their point of view, their experience, their needs with other people around them. So those might just be some things to keep in mind too, because those aren't going to be super easy to measure quantitatively, unfortunately.
wow.
I think it's a really good point, and I think it touches on also, you know, you can measure preferences on patients, but are those patients represent? How do you, again, make sure that the preferences you're measuring, if you're using them to inform a trial, are representative of different groups and yeah, equity considerations within that.
Excellent point.
Can I add to that, Bev?
Yes, for sure, Maureen. Thank you.
I'll put my camera on. You can get my COVID look. So I'm just going to give the example of osteoporosis. So I was diagnosed with osteoporosis in my late 20s, which is unusual. And so my concern would be if the patient preferences around osteoporosis treatments are based on the typical age of osteoporosis, that may not have been my preferences at that age. So how do you create a system where you're capturing the preferences of the outliers, so the people who are that small population who are different, you know, and not having that those preferences represent the whole group, and catching those individual differences, because the whole concept of patient preferences is so important. Like, I'm very supportive of it, and but you want to, how do you make it so that you've got you're taking into account the people who basically are the ones who are not represented by the main group.
Nick, did you, I know you've...
Excellent example.
Yeah, no, I think thanks, Maureen. And I think that's where, like, right now, when you sort of see these trials come out, they often have like a single interpretation that this is best for all people. And I think what this group can help sort of in the future is change that. Like, it could be that is best for everybody, but it could also be that there's going to be some groups that one treatment is best for you, and the interpretation may be different for other groups. So I really think spending more time working out the heterogeneity or the differences in our patient populations, listening really well, to how they have different preferences, and thinking through interpreting results that are meaningful to them and relevant to them is going to be the future of how trials will be, sort of like the results will be displayed.
So if I can just build up on that to talk about why this is so critical. So if we think back to Glenn's example with the 20% difference, you know, when you're designing a trial, you have to decide at the design phase, what difference are you going to look at? Because you're going to collect a certain number of people to find that difference. So if we assume, like Nick just said, that all patients care about a 20% difference, right? Then our trial will only be designed to look at that. And at the minimum, we could think about if we show that there are groups of patients who really care about a 2% difference, and there are patients who would only take that medication for a 70% difference, then we need to think about, before we start recruiting people, that we have to design a trial to account for those differences. I mean, to me, that happens over and over again. You know, we design trials for 20% difference. You all know about the ACR 20. It's a perfect example, and many of our patients would never take a drug for a 20% improvement. So why are we designing trials to look at that? You know, and it might be, as was just said before, there's going to be big groups of patients who demand different things, and which is fine, but we should know that before, right? So either we design one big trial to allow for that, or we design different trials to acknowledge that different patients will have different trade-offs. Because otherwise, like Nick said, we're really answering either nobody's preferences at the worst, or a small, because we know that patients feel differently. And even somebody just before said they've changed their preferences 100 times throughout their illness, which makes complete sense. It's going to depend on so many things. So I think you're all bringing up exactly why we feel that this is really important.
Okay, this is great. Maybe we'll, I know there's a few more comments we haven't gotten to, but I want Megan to have enough time to present her slides as well, and there'll be time at the end for more discussion too. So,
Great, thanks.
All right, Megan, go ahead.
All right, yeah, really good discussion, everyone. So I'll move on here. So for our research plan, the first phase of our research is a scoping review of the literature to see how preference-based methods have been applied to the design of clinical trials. Next, we want to engage with various stakeholders, including patients, clinicians, and researchers, by conducting one-on-one semi-structured interviews. And we're hoping that by collaborating with different stakeholder groups, we could be able to understand how, when, and with whom these preference-based methods should be used in the evidence continuum of clinical trials. So for our scoping review, we were interested in finding examples of how preference-based methods have been applied to clinical trials, particularly the design, in any health condition. So to identify our primary studies, we began with a search of existing systematic and scoping reviews. However, after extracting 947 primary studies, we realized we were not identifying very many studies using preference-based methods for the design of trials, and we were getting a lot of duplicates between the reviews. So we conducted a supplementary search in order to identify primary studies from 2014 on. And we feel that this way we will be able to capture primary literature that wasn't included in a review for whatever reason. So we're on to the full text stage here. So far we have 9 primary studies included, bringing us to 12 to date. So of our current inclusions, the most notable applications of preference-based methods in clinical trial design has been to produce preference-weighted composite outcomes, which Nick talked about earlier, for endpoint selection and informing the choice of outcome measures, and then allocation of patients to their preferred treatment in a trial arm. So for the second phase of our research, I mentioned we'll be doing semi-structured interviews. And the aim of this is to explore the perceptions, barriers, and facilitators of using these preference-based methods in clinical trials in rheumatology, according to our various stakeholders, including patients, clinicians, and researchers. And I think with the discussion that you guys brought up quite a few of the barriers currently and the things that we need to consider. So these are all things that we really need to know if we're going to develop guidance. So far, we've done 4 pilot interviews here, 2 with clinician researchers and 2 with patients. And you can see here that there are some points being made regarding the importance of using preference-based methods. One clinician participant identified that priorities are different when we're making treatment decisions, and this can impact and influence the way trials are conducted. Our patient participants pointed out that these decisions impact their day-to-day lives, and thus they require sufficient information and opportunity to express their preferences upstream, so in the trial design stage. In terms of next steps, we felt that we had great discussion and interest in the topic. However, based on feedback, we're going to be shifting our approach to focus on examples. For example, the ones that we were talking about earlier today, and then ones that we identify from a scoping review, in order to better explore how perceptions might change with an actual focusing sample within the interviews, and how that might change depending on the type of stakeholder we're interviewing. So with that, a little plug, we'd love to hear your input. We're recruiting now. So if you or anyone you know would be interested in participating, please email us and let us know, and we can provide you with more information on how to do that and get involved. So I think we have another poll question here coming up.
Okay,
so the
great.
same one. Yeah.
Yeah, sorry, Megan. Okay, so I think we're better. I think we've kind of moved people out of those bottom groups into the middle or higher, so that's great.
I'm just picking up on the chat here, Glenn. I think Niti, I hope I've pronounced that correctly, brought up this point about selecting the right outcomes, and I think hopefully that's been addressed. So going back to Liana's example about the ACR 20, like maybe if we'd asked patients, we wouldn't be using an ACR at all. So I think that's one of the findings in the review that Megan did, was actually asking patients actually what outcome would be a meaningful one to include into a trial.
Yeah,
it's not, I don't know if you can hear me, it's not just about picking the outcome that would be meaningful for patients, but putting outcomes in that measure how meaningful the outcome was to patients, which is a completely different way to ask. And so the treatment satisfaction questionnaire and the patient global impression of change are, for example, 2 outcomes that measure the importance of the outcome to the patient.
And might I also add to that, there's sort of layers of this, isn't there, in the context of also what would be the threshold that becomes the tipping point where it would be acceptable or not acceptable to patients. And there are good examples now in the real world where patients would have been quite happy to accept the risk of certain drugs, but those drugs were withdrawn from the market because overall it was deemed to be an unacceptable risk. But for certain patients, for example, it was a reasonable risk given the trade-offs of the benefits. And I know that's a withdrawal example, but to me, it's quite analogous to be able to understand, you know, what are the benefits and the risk trade-offs and what matters in terms of measuring outcomes in trials and getting the metrics right. And then also being able to make sure we get the tipping point, the amounts right as well, the effect sizes.
Yeah, I think the Vioxx example is a good one of that in rheumatology, right? Where people were really upset when they couldn't take their Vioxx anymore for a small, and willing to take the, willing to accept that risk. Yeah. Megan, was there any other slide? Was that the last? Oh, we do have more slides, okay.
We've got lots of good volunteers here in the chat, so we'll keep track of anybody who is send notes to them after. So please add your name if you're, I see Catherine and a few others have volunteered for your studies.
Yay, thank you. That's
Yes,
great.
thanks.
You're going to be doing a Delphi, so you're also going to need lots of participants from that as well. So.
Okay, great. Next slide. So yeah, so then we wanted some thoughts on, there's lots of different ways we could go with this group. We think finding an example to kind of work through might be a useful thing. So just wondering where people see the most utility for this group would be. Okay, so bit all over. The most is all of the above, so that'll keep us busy for the next 10 years, Megan. Okay. Okay, and then the last one was just on some general discussion. We can talk about what's in the guidance as well. We really want to know what the output from this SIG should be. So we've thought of developing a guidance document, which is, I think, something we'd like to do. We'd really love to look for applied examples with other OMERACT groups. So if you have, if this has piqued your interest and you think there's other ongoing work where this could be applied, that would be great. Yeah, so, and then have we missed any key stakeholders? And we wanted to throw out, do you think this work would be relevant across rheumatologic conditions? Or are there some where it's more relevant or not? Okay, and I think that was it. So thank you, everybody. That was great discussion so far. I haven't been, Nick, have you been having a look at the chat, or Bev? Some other...
Yeah, there's still some volunteers, Maureen. And the osteoporosis example was fantastic. So so did I miss anything? There's lots of volunteers. I think Catherine also said, I think it fits well with both the equity group and the shared decision-making group. We've said that before. This is a methods group, and so you're totally right. We'll have to see how that all comes together, but Peter's on, Peter Tugwell, and he's been encouraging these guys to work together. So we'll make that happen. Lots of volunteers again. We'll get back to you about all of that. It's relevant for all of medicine, isn't it, Rochelle says. Diana, to determine clear data, no treatment effectiveness and adverse events is needed first. Diana, did you want to speak to that, or? That's a good point.
You asked me if I want to speak about my question?
Yeah, to determine the preferences, clear data on it. That's a good point there. Would you like to speak to that so Glenn can?
Well, I can only explain from my personal point of view. So I take care of my 83-year-old mother, and so I want to minimize the risk of any adverse events that could possibly interfere with my wish to be able to continue to take care of my mother. So I'm not taking any medicine. So therefore, for me, it's very important to be able to determine what your exact preference are. First, you need detailed information about exact chance on success or adverse events So that's why I'm saying that's first needed.
Excellent point. Thank you. Glenn, did you want to?
Yeah, no, I think that's a good point. I think they can be complementary to, so and ideally as we're generating the data on, which adverse events to measure, which benefits to measure, what's an important benefit, we consider preferences at that stage. So the information we generate on the benefits and harms is more relevant for people's decision making, I think. Yeah.
Excellent. Thank you. Francis, do you want me to read it, or would you like to speak about bias and participation towards already interested people? It's a very good point.
Yeah. Megan, maybe I could let you talk about this, because we have talked about that.
Francis.
Yeah. I mean, that's a really good point.
Just wanting to know whether some policymakers were member of the SIG, because it's probably a goal of this group to promote that to policymakers. If they are already there, would be good.
Yeah, absolutely. I think we've talked about this like a lot, because we do want to get people who have interest in the topic, but we also want to make sure we're representing patients, the clinicians and researchers who might have no idea how preference-based methods could be used in trial design, and speak to it in a more novice sort of way. So we want to get a range of expertise as well. So we definitely do want people from OMERACT within our little circle here, but we definitely need to branch out and think broader as well.
Yeah, I agree.
And
go ahead, Tim.
Oh, sorry, Bev, I was just going to jump in and say, and so we have a couple other strategies in order to get people broadly recruiting through different patient groups. But if you know people as well who you think might be good from a non-expert or perspective, please feel free to pass on an email. And thank you to everybody for volunteering. We'll be reaching out. We may not be able to get everybody, because Megan has to finish her master's at some point, but we're trying to get as representative as we can. So yeah, we'll be reaching out with that.
And Maureen Smith mentioned about a guidance document that contains applied examples. So I think that's really important. You've had some of those discussions today. And I think that's your plan for the OMERACT handbook as well, right? To give guidance in the handbook for people doing this in OMERACT and outside. So
yeah, that's exactly right.
Yeah. So I think
just to kind of comment on a couple of the questions coming up. I think one thing that we need to kind of be careful about, and what distinguishes us from the shared decision-making group, is that this is about the design stage of the trials. And so, like Hinder, I see your question about sort of people making decisions about their own care. In a sense, this is about designing a study that then would allow a physician to sort of better be able to make a shared decision with their patient, because the trial is providing the information that can better reflect the preferences of different patients. So I think that's something we need to be careful to sort of make sure we are focused somewhat on that, rather than the broader sort of preference question. But my one thought is that we maybe need to sort of consider ethics if we're kind of talking about design, because this may influence like consent forms and ethics committees. So I think there might be another stakeholder for us to incorporate.
Yeah, that's a great point, Nick.
So where were we? I'd like to be involved. There's lots of volunteers. It's great. Well publicized Delphi from Maureen. Well reached. Anthony says, I think Diana's point is important and raises a question in my mind about the types of trials patient preferences will be incorporated into, phase 3 trials prior to approval or post-approval trials, or both. Who would like to take that one?
Yeah, I can speak to it. I think, Nikki, I know you've thought about this as well. I think you've done some interesting work showing that, if you measure preferences beforehand, there's some trials that probably shouldn't have even been done, because they're not powered to show meaningful differences in in benefits and risks, or they should have been done differently, maybe. So I think it all, I mean, at this point, it's kind of baby steps. You know, if it's done right, I don't see much of a disadvantage in doing it at any stage of the trial. So ideally as early on as possible. But yeah, I think a lot of that's a matter of showing the importance and the impact and the value added of doing this work within the context of trials.
And I don't know who would like to take this one, but I know Hinda says, I know people who would not want to be making decisions for their own care and would prefer their physicians to make them. Megan, you're shaking your head.
Well, that's the preference too, I think, right? To make sure that they have that opportunity to express their preference if they like to, but of course, if they don't want to, that's, I think, a preference as well. And that's fine too. But I think it's important to make sure that we're looking at both ends or the whole spectrum and making sure that everyone's needs are being met.
And there are scales to measure sort of preferences for shared decision making, and most patients don't want to be making the decision entirely on their own. A lot of patients want to defer to physicians, but typically the patients who want the physicians to be making, they typically want their physicians to do it with them in mind. That's sort of what the scales. So very few patients want their physician just to make the decision entirely on their own with the physician's preferences. They want them to be incorporating something of their values when they do it. But I think if you, you know, if we think about these things during the design, again, coming back to thinking about these things at the early stages of trial development, you know, even if the physician's making the decision, maybe they're making the decision based on more patient relevant outcomes or trade-offs for that person.
Yeah, I agree, Glenn. And I'd just like to add as well that this comes back to this whole discussion around heterogeneity and understanding really how patients make decisions and what's important to those individual patients. And part of that is really about their decision-making style and essentially what we talk about in terms of their locus of control. So there's a whole literature around that in the sense that different people have a different propensity or desire to be involved in decision-making for their own health or less. And there's a lot of different factors that would go into that. So it could be something that could also come into play just in this whole context of the heterogeneity and different ways in people value different things, but also the decision-making process. So I think it's a combination of both.
Great.
Just picking up on some more comments here. I see Pam's brought up the deaf community and Hinda about sort of caretakers, caregivers, I think. And just thinking back to sort of Grayson's comments earlier on, I think the message here, Megan, is when we do these interviews, we need to sort of make sure we're listening to diverse voices of experiences and sort of not just the one or two. Is there anything, Pam or Hinda, you want to sort of add to that?
For me, it's Pam. The deaf community, as well as some others, are often missed out on design. They have their own culture. They have their own, obviously their own languages. And the way they express themselves is not in the format that we express ourselves in sentences and things. So I think we just need to be aware that the deaf community should be asked how they think trial design is conducted, etc. Because it could be quite different from what we imagine as English or English speakers or French speakers. We're not sign language speakers. We communicate differently from them.
Great, thanks.
I brought up the issue of caregivers because I'm thinking that with a lot of diseases, many of these, decisions have a fallout on caregivers big time in terms of acute issues that can come up and support for the patients. And they were just not mentioned here. So I was thinking that that might be useful to think about. So.
That's a great point too.
Yeah. I'd just like to underscore that as well, because we know from the preferences literature that the viewpoints of caregivers and also care providers, a la clinicians, are often quite different than patients in terms of which aspects of the care are valued more or less. And it's not that those aspects wouldn't be valued at all, but it's about sort of the weighting or the degree to which they're important. So people might order them differently. And we know that based on, patients, caregivers, or physicians, there is a difference in the ordering.
Great, thank you. Karine, would you like to speak to your point about it being complementary to the decision-making, to the shared decision-making group work?
Yeah, sorry, I have my kids around me like talking. So yes, yeah, I think it's really complementary. So we're really dealing with outcomes that are important and assessing the effectiveness and safety of shared decision-making interventions. And you're really taking into account all the patient preferences in order to choose outcomes, to design the best trials possible. So I think it's really complementary and it's very important what you're doing. I think it's going to be very interesting to see how you take into account the patient preferences, right? So I guess, would you usually do a study where you would have a wide range of patient preferences, people from different, with different characteristics, and then from these studies, you would kind of see if they're typical, like different types of outcomes, different types of cutoffs for outcomes that would be needed, different ways to do a trial, and then how do you decide? I think that question was asked before. How do you decide what to do? Or could you do also in a trial, each patient preferences, and then is there a way to kind of decide on how a trial is done for the whole, like all the patients in the trial, but also is there personalized elements that are added? I don't know. So my thoughts.
No, those are all super great. I think all of those things you mentioned in terms of how to do it are ways that preferences can be applied within trials for sure. Yeah.
Great.
Thank you.
There's lots of other. Do you see anything there, Nick? There's lots about the work, the equity group, and the ethical question.
Yeah, and I was just going to point out Pam's comment about, to express a preference, a patient must be adequately informed. We made a lot of these things seem very simple in terms of how to measure preferences, but there's a lot of nuance that goes into it. Yeah. How do you get the right groups? How do you make sure the instrument you're using is understood, that what you're measuring is truly what you're measuring? So there's a whole host of methodological issues that I don't think this group will take on all of them because there's other groups that are working on that. But those are some of the key things when you're designing these studies. Absolutely.
And then Maureen's point about the ethical questions when patients and caregiver preferences do not align on the same topic.
Yeah, I think it's another good point. I mean, I think a lot of the times, as we've seen, a lot of these trials are done without any formal consideration of patient preferences. So you could argue is, even if we start making baby steps and doing some of it, is that better than nothing? And I think preference information could help understand those differences where caregivers and patients don't align, or caregivers and any of the stakeholders differ in terms of the preferences. And there's lots of studies out there showing that physician and patient preferences are often very different for a whole host of health conditions.
Nick, do you see anything else? There's something about the writing it up, but do you see anything else that we may have missed, or does anybody have other?
I think we're making notes of this. I think the write up is obviously about the dissemination. You know, making the way the trials are, even if we design them well, if we don't communicate the results well, then it's kind of pointless. So I think that's a great point. Liana, you have a thought about that?
Well, no, I was actually I was actually thinking about something else. Can I mention the other thing I was thinking about that based on the discussion? So I just want to reiterate what both you and Deborah said before, was I think, and in the shared decision-making group, we've had the same issues. I think we just need to keep the main objective on our blackboards in front of us to say that this is really a trial design issue, and more to get the people who matter the most, their input on boundaries, really. You know, what are the outcomes? What are we aiming for that is most important to this patient population? And to not have somebody who has never experienced this disease, not the one who has to live with the pain, et cetera, make a decision of 20% versus another percent. So your profile of how you want to engage in shared decision-making is very related, but it's a distinct concept. This is not choosing between two medications. It's choosing what is an important difference for two medications. You know, how much benefit do I need to even consider taking an injection daily? You know, it's very much what we've heard from other big groups like PCORI. What is really important to us? What should we be measuring? Which surprisingly is just, I mean, to me, it's really surprising it's not already done. The other minor point is that there is some good news in terms of how we can, you know, involve patients in different trials, right? So if we're doing trials for an early RA population, right, a lot of people brought up my preferences have changed, how sick I am makes a difference 100%. So you can imagine that for an early RA trial with patients with very mild disease, right, the patients who would participate in that and the preferences that we would measure for that would be different for a trial that looked at something completely different. Right? So that actually we do have some control over, and because there are eligibility criteria for all these trials, that would help us make sure that at least we had some idea to include the right patients in those decisions, because they're the ones who are actually living with that issue, and they are expected to differ. So I think that is a little bit, you know, that'll help us a little bit decide on, you know, trying to make sure that we have the right input from the right people for the right trial.
Oh, and Maureen had a clarification there. It's not so much about the issue for when the physician and patients do not align, but it's how much weight to give the caregiver preferences when it doesn't align. So I think that's also important to clarify there.
Yeah.
Great points, everyone.